Okay, I'm actually going to move on to AnaMaria Vasquez from the University of Antioquia, who's going to present on the performance of the HS-RDT or ultrasensitive RDT, HRP2-based RDT in pregnancy.
Good morning. Again, my name is AnaMaria Vasquez. I'm working at the University of Antioquia in Colombia, and I'm going to share with you the results about the performance of the ultrasensitive RDT for detecting falciparum in pregnant women in Colombia. As many of you know, malaria during pregnancy is associated with adverse outcomes in maternal and neonatal health, including anemia and overweight. The impact of infections in low transmission settings as Latin America has been less studied. In this region, there are around 4 million of pregnancies at risk of falciparum and virus infection each year. And compared to high transmission areas in Africa, intermittent preventive treatment is not recommended, and early diagnosis is central for preventing malaria in this region. There are two main strategies. The first one is the active detection of cases during the antenatal care program, and the second one is the passive detection of clinical cases at health facilities. In Colombia, both falciparum and virus are prevalent in similar proportion, and 80% of cases are concentrated in the north and in the Pacific region in the departments of Antioquia, Chocó, and Nariño. Related to malaria in pregnancy, most of the studies have been conducted here in the north region where virus is predominant, and the prevalence of infection during pregnancy reported in this study was between 1 to 30%. However, in recent data, the prevalence of infection was around 1% in the north region of the country and around 4% in the Pacific region of the country where falciparum is predominant. Using molecular techniques as PCR, the prevalence increased, and around 50% of infections in pregnant women were submicroscopic. National Health Authority in Colombia recommends the screening of malaria during the antenatal care visits in all pregnant women living in endemic areas in Colombia. However, this recommendation has several limitations, including, for example, its implementation remains irregular in some places, and we don't have information about the compliance to this strategy in all municipalities with malaria in Colombia. Also, there are limitations related to the access to antenatal care service, especially in the poorest region of the country. And we also have some limitations related to the quality and sensitivity of diagnosis. In Colombia, microscopy is the routine test for the diagnosis of malaria, and even if this test had a very good sensitivity for the detection of clinical cases, has some weaknesses in the context of antenatal care service, as for example, needs expertise, infrastructure, and it is a time-consuming test. Also has less sensitivity for the detection of low-density infections. And it is important to highlight that there is now published data about the quality control of malaria smears from pregnant women in our country. Alternatives to microscopy includes rapid diagnostic tests, but they also have some limitations. Both microscopy and RDT fail to detect a large proportion of infections detected by molecular techniques as PCR. So current data suggests that a sensitive and an inexpensive field diagnosis is necessary for antenatal care programs, not only for supporting diagnosis of malaria in pregnancy, but also contributing to transmission control. And for that reason, we aim to evaluate the performance of the ultrasensitive RDT for the detection of falciparum in pregnant women in Colombia. The ultrasensitive RDT, as you heard before, was developed for the detection of low-density infections, and compared to a standard RDT, has an analytical sensitivity 10 times better. The performance was evaluated in two studies, one retrospective using samples collected from pregnant women in 4 municipalities of Colombia located in North and Pacific region. There are Urabá, Bagre, Quibdó, and Tumaco. and in a prospective multicenter clinical trial conducted in Colombia and also in Papua New Guinea. In Colombia, pregnant women were enrolled in the municipalities of Quibdó and Tumaco, located in Pacific region. In both studies, the participants were pregnant women self-presenting at local hospitals for antenatal care visits, and in the retrospective study, women at delivery were also included. The principal outcome evaluated was the performance of the ultrasensory RDT and also the routine test microscopy, the standard RDT, and the molecular technique LAMP. The gold standard used in the retrospective study was an ASTMH18, and in the prospective study, a quantitative RT-PCR. In a general overview, in the retrospective study, a sample of placental and peripheral blood were collected, and on field side, the diagnosis was performed by microscopy, standard RDT, and LAMP. The standard RDT used in this study was PFPV for the detection of falciparum vivax and mixed infections. An additional sample of blood was frozen in order to perform additional tests. On central lab at the university, the ultrasensitive RDT testing, quality control of microscopy, and nested PCR were performed, and we also include a second standard RDT for the detection of falciparum in frozen samples in order to discard antigen degradation due to sample freezing. In the prospective study, the ultrasensitive RDT was tested on field conditions, and samples collected for the QRT-PCR were transported to University of Washington, where the reference test was performed. A total of 737 pregnant women were included in the retrospective analysis of the performance of the ultrasensitive RDT. This is the general characteristics of this population. The median age was 23, around 40% were primigravid, and 3% had fever at enrollment, and around 7% had history of fever during last 3 days. Women with fever or history of fever were classified as symptomatic. Here we can see that the prevalence detected by microscopy was 4.2%, and detected by PCR was 5.3%. And as you can see here in the gray bars, most of the infections were caused by falciparum in peripheral and also in placental samples. In this table, we can see the number of positive samples for falciparum detected by each test. And according to the nested PCR, which was the reference test, the prevalence of falciparum was 4.7%. According to the true positives detected by the reference test, the ultrasensitive RDT detected a prevalence of 4.1%, and as you can see here, the standard RDT and the routine test microscopy detected less infections in comparison with the ultrasensitive RDT. Related to placental samples, in general, we observe a low prevalence of infection. Nested PCR detected 2.8% of infections, the ultrasensitive RDT detected 1%, and the standard test detected 0.7%. It's important to mention that 46% of these infections were febrile. Related to the performance, the ultrasensitive RDT had better sensitivity for the detection of falciparum in peripheral blood from pregnant women as compared to microscopy and standard RDT PFPV. As you can see, the sensitivity for ultrasensitive RDT was around 86% compared to 77% for microscopy and standard RDT PFPV. All tests had high specificity, and the other parameters were similar between them. However, as you can see here, the ultrasensitive RDT had a lower predictive positive value due to some false positive results detected. In symptomatic pregnant women, all tests had high sensitivity for the detection of these febrile infections. However, in asymptomatic pregnant women, microscopy and standard RDT PFPV failed to detect half of the infections identified by the nested PCR. Although URDT also missed some cases, had higher sensitivity for the detection of these febrile infections in pregnant women. Related to the detection in placental samples, in general, we observed that ultrasensitive RDT detected more infections than microscopy and standard RDTs, but the number of infected placentas was so low to draw a conclusion. As you can see here, we only identify 8 infected placentas by falciparum. From those, the ultrasensitive RDT was able to detect in placental blood 37%, compared to microscopy and standard RDTs, which detected 25% of infections. Here it is important to highlight that in peripheral blood, neither microscopy or standard RDT PFPV were able to detect any of the placental infections identified by the nested PCR. However, the ultrasensitive RDT was able to detect 3 of these placental infections in peripheral blood. And this is an interesting observation due to that the access to placental tissue during pregnancy is impossible, and an ideal test for malaria should be able to detect placental infections in peripheral blood. However, as I said before, the number of infected placenta was so low, and this observation needs to be evaluated in larger studies. Related to the clinical trial for the evaluation of the performance on field conditions, a total of 858 pregnant women had complete data for the analysis. These are, again, the general characteristics, and around 10% of the pregnant women had history of fever during at enrollment. And in this table, we can see the prevalence of infection detected by the different tests. Microscopy identified 2.7% of infected pregnant women, and qPCR 5.5%. As you can see here in this graphic, most of the infections were caused by falciparum. Ultrasensitive RDT detected more infections than standard RDT, but less infections than molecular techniques, as for example LAMP. And related to the prevalence of falciparum, the qPCR detected 4.5%, the ultrasensitive RDT detected 2.9%, and less infections were detected by standard RDT and also by microscopy. This is the performance of the different tests. As you can see, again, the ultrasensitive RDT, As you can see, the ultrasensitive RDT had higher sensitivity compared to a standard RDT for the detection of falciparum in peripheral samples from pregnant women, with a value of 64% compared to around 54%. In this case, LAMP had higher sensitivity for the detection of these infections in pregnant women. And the additional cases detected by the ultrasensitive RDT compared to the standard RDT were 10%. In this slide, we can see the parasite density according to the qRT-PCR results. In general, we can see here that all tests were able to detect all infections with parasitemia higher than 100 parasites per microliter. And here in this table, we can see that the geometric mean of parasitemia from the samples detected by the qPCR was 15 parasites per microliter. And here we can see that the minimum parasitemia detected by the standard RDT was 42 parasites per microliter in comparison with the 0.8 parasites per microliter detected by the ultrasensitive RDT. And here we can see the parasite density among positive and negative RDTs. On the right, we can see samples positive by the standard RDT and also by the ultrasensitive RDT. The mean parasitemia in these samples was higher than 100 parasites per microliter. On the middle, we can see the the samples only positive by the ultrasensitive RDT and negative by the standard RDT. And we can see that the parasite range was between 1 to 40 parasites per microliter. And here we can see the samples detected only by qPCR, but negative by both RDTs. These parasitemias was very low, under 1 parasite per microliter. So we think that there are 2 important questions to address related with this parasitemia. The first one is what is the clinical impact of these low-density infections that remains undetectable by the standard test and also by the ultrasensitive RDT. And the second question is, what is the potential impact of detecting these additional infections that standard RDT couldn't identify? In the asymptomatic pregnant women, again, microscopy and standard RDT failed to detect half of the infections identified by the PCR, and although ultrasensitive RDT missed cases had, in this case, higher sensitivity compared to the standard RDT. Finally, we also evaluate the presence of gametocytes among infected pregnant women, and we find that around 56% of infected pregnant women detected by microscopy had also gametocytes of falciparum. And the prevalence of gametocytes was higher in the pregnant women with a febrile infection. So as general conclusions, we observed that the ultrasensitive RDT had a better sensitivity for the detections of infections in peripheral and placental blood from pregnant women living in low transmission settings as Colombia as compared to microscopy and standard RDT. This improvement was more evident in asymptomatic infected pregnant women where microscopy and standard RDT meets around half of the infections. Also, the ultrasensitive RDT could be an useful test for detecting placental infections and peripheral blood that remain hidden with microscopy or standard RDTs, and a significant proportion of infected pregnant women had also gametocytes of falciparum detected by microscopy, suggesting that this population it is an important reservoir that contributes to transmission and must to be included in the elimination strategies. And what is the implications? As I said before, the antenatal care programs needs a sensitive, easy to perform and inexpensive diagnosis to identify infected pregnant women. And the ultrasensitive RDT compared to the standard RDT has a similar cost, is also easy to perform and had a slightly better sensitivity for the detection of these infections. So in this sense, we think that could contribute to detect and treat malaria during pregnancy and also identify women harboring low-density infections that can contribute to transmission. Further studies in different settings are needed for the evaluation of the performance of the ultrasensitive RDT, detecting infections during antenatal care visits, also detecting placental infections in peripheral blood, the cost effectiveness of integrating this tool in the A&C programs, and the potential impact of detecting these additional infections. Other issues that I think that should be addressed related to this topic is the impact of submicroscopic infections on pregnancy and birth outcomes, and in other words, is what level of sensitivity we needed for testing malaria in pregnancy. It is also too important to address the detection of falciparum infections with HRP2, HRP3 gene deletions. Of course, in countries as Colombia, we need more sensitive tests for VIVAS. And finally, it's important to know what is the contribution of different kinds of infections in pregnant women to transmission of malaria. Thanks to all people working in these projects, and thanks to the participants, and thank you for listening.
Are there any clarifying questions? Otherwise, I'll hand it over to Xavier Ding from FIND